Lichen planus was first reported in 1869 by Erasmus Wilson, and the origin of the word is believed to be from the Greek word lichen, which means tree moss, and also from Latin word planus, which means flat and even surface. Lichen planus. What do you mean by lichen? Lichen is a composite organism that arises from algae or cyanobacteria living among filaments of multiple fungi species in a mutual relationship. The combined lichen has properties different from those of its component organisms. Lichens may come in many colors, sizes, and forms, and the properties are sometimes plant like, but lichens are not plants. Lichens may have tiny leafless branches, and that is called fruticose, flat leaf-like structures, folios, or flakes that lie on the surface, fructose. Lichen planus is a chronic inflammatory and immune-mediated disease that affects skin, nails, hair, and mucous membrane. Characterized by polygonal, flat-topped, violaceous papules and plaques with overlying reticulated, fine white scales, and these are called Wickham's striae. It commonly affects dorsal hands, flexural wrists, but more commonly oral mucosa. The cause is unknown but thought to be the result of an autoimmune process with an unknown initial trigger. There is no cure, but many different medications and procedures have been used in efforts to control the symptoms. Lichen planus. What do you mean by a lichenoid reaction? This refers to a lesion of similar or identical histopathological and clinical appearance to lichen planus. Sometimes dental materials or certain medications can cause a lichenoid reaction. They can also occur in association with graft versus host disease. The lichenoid reaction refers to a lesion similar to lichen planus. How do you categorize lichen planus? They are categorized as either cutaneous or mucosal. What is the most common form is the papular variety. This is a classic lichen planus characterized by shiny red or purple colored flat topped papule. Please note purple colored, and that is often a spot diagnosis. Lesions may have a thin transparent or adherent scale with fine whitish points, and these are called Wickham's striae, seen on the surface of well developed papules. What are the various types of lichen planus? We have papilla, we have annular, we have linear, hypertrophic, atrophic, bullous, actinic, ulcerative, and pigmented. And lastly, follicular inverse varieties, the various forms of lichen. Although lichen planus can present with a variety of lesions, the most common presentation is a well-defined area of purple-colored, itchy, flat-topped papules. Repeat again, purple-colored, itchy, flat-topped papules interspersed with lacy white lines, and these are called Wickham's striae. Now, this description is known as the characteristic 6 P's of lichen planus. They are planar, purple, polygonal, pruritic, papules, and plaques. The characteristic 6 P's of lichen planus. Here is a case of lichen planus on the lips and the lateral border of the tongue. There are various varieties of lichen planus. They are reticular, erosive, papular, plaque-like, atrophic, and bullous. Generally, oral lichen planus tends to not cause any discomfort or pain, although some people may experience soreness when drinking or eating acidic or spicy foodstuffs. And when symptoms arise, they are most commonly associated with atrophic and ulcerative subtypes. These symptoms can include a burning sensation to severe pain, and they may also experience mucosal bleeding in response to mild trauma. Now, what do you mean by the Coppa phenomenon? This is the development of new lesions at sites of trauma. Cutaneous lichen planus is a self-limiting condition resolving within 6 to 12 months. Oral lichen planus is a non-infectious chronic inflammatory condition that involves the oral mucosa and may be accompanied by skin lesions. Etiology is unknown. Now, it is not clear whether mechanisms causing isolated oral lichen planus are different from those causing cutaneous. An immune-mediated mechanism where basal keratinocytes are being targeted as foreign antigens by activated T cells, especially CD8 plus T cells, has been proposed. Upregulation of intracellular adhesion molecule and cytokines associated with T helper 1 immune cell may also play a part in the role of pathogenesis of lichen planus. Stress is thought to play a role in the pathogenesis of oral lichen planus, and patients with anxiety and depression are reported more commonly with oral lichen planus if compared to normal healthy individuals. Some studies have indicated that stressful events can induce lichen planus lesions in otherwise healthy individuals. Autoimmune response to epithelial self-antigens remains a possibility, and a single study of cutaneous lichen planus reported evidence in support of autoimmunity by expanding in vitro T cells isolated from the skin lesions of 2 patients, followed by testing the ability of these T cells to kill autologous keratinocytes. Pathogenesis. Oral lichen planus is considered to be a T cell mediated chronic inflammatory tissue reaction that results in a cytotoxic reaction against epithelial base cells. The inflammatory infiltrate in oral lichen planus is primarily composed of CD8 plus T cells. A potential pathway for CD8 plus T cell mediated cytotoxicity has been described. There is no cure for lichen planus, and therefore treatment is for symptomatic relief and medical treatment is pursued. First line treatment typically involves corticosteroids and removal of any triggers. Without treatment, most lesions spontaneously resolve in about 6 to 9 months. How do we manage oral lichen planus? Reassurance that the condition is benign, elimination of precipitating factors, improvement of oral hygiene are considered initial management for symptomatic oral lichen planus, and these are usually useful. Treatment involves topical corticosteroids, analgesics, and if the condition is severe, systemic corticosteroids. Of late, calcineurin inhibitors are sometimes used.